Hello, everyone. Dr. Alex Vasquez here, and right now I'm going to talk to you about gas and bloating. Some of you might consider this to be a rather boring topic, but let's appreciate it for what it is and see if we can gain some insight into these kind of benign or banal symptoms and appreciate the fact that these actually affect a big part of the population. About 1 in 3 people, about 30% of the population at one time or another has gas and bloating. And furthermore, we can see this in terms of clinical practice as a potential, area that we might at least specialize in somewhat. Again, it is 30% of the population. That's a big patient group to work with. And I think if we understand gas and bloating, we can actually gain some big insights into helping these patients to get better. So on this diagram, on this page, I've outlined the pathophysiology of food intolerance in this regard, at least with regard to gas and bloating, and how we can correct this. So here are the problems, and all we have to do as clinicians is reverse these problems, and then we have the solution. So hopefully that helps you understand gas and bloating at a deeper level, but of course it doesn't because you can probably barely read this handwriting. So let's look at some actual details that we can incorporate into our understanding and also therefore into clinical practice. So the vast majority, when people talk about having gas and bloating, they're usually talking about gas and bloating that results from microbial fermentation. Sure, some people can get some gas and kind of, it's not really bloating per se, from swallowing air. That typically only accounts for about 20% of intestinal gas. And people have some control over that if they slow down, if they chew their food. Maybe they have sinus congestion or sinus problems that they need to remediate or remedy so that they can breathe easier through their nose and not have to breathe through their mouth while they're trying to swallow food. Things like that. Those are some considerations, and you can see those and some others listed here on this page. But we're going to focus in on the microbial fermentation because that certainly accounts for the majority of gas and bloating. Gas production within the gastrointestinal tract, but also as microbial fermentation becomes more prolific, we might say, and this problem proliferates in the volume of gas and bloating that's produced, and the pain and secondary consequences and things like that, we need to understand that it's originating from microbial fermentation. A lot of times we see this with small intestine bacterial overgrowth and irritable bowel syndrome and fungal overgrowth within the intestines. So we need to understand that someone's complaint of gas and bloating might kind of sound boring or banal at the outset, but we need to take it seriously because it could represent an opportunity for us to help these patients. And again, it's at any point in time, it's 30% of the population. So let's look at some contributors to this problem. So when we talk about microbial fermentation, that is what results in postprandial gas and bloating. So typically after people have eaten food, especially if it's difficult to digest carbohydrates or an abundance of fermentable carbohydrate, for example, in wheat and potatoes, a lot of people will develop, again, what I said here, postprandial gas and bloating. That is the kind of signature for small intestine bacterial overgrowth and also irritable bowel syndrome. So again, some causes of this include rapid eating, nasal obstruction, swallowing air, overeating or just excess eating, overwhelming people's digestive capacity. So sometimes people go on a buffet binge of, French cheese pizza, and maybe that gives them some pretty bad gas and bloating for the next couple of days. And that's what happened to me a couple years ago when I went to Paris. I had a 4-cheese pizza. First of all, I usually don't eat those types of cheeses. Second of all, I don't usually eat pizza, and certainly not a whole pizza. But I did, and I was sick the next day. So, we have to look at gas and bloating within the context of what is the patient eating. If their diet is horrible and they get gas and bloating, then we can say, hey, we need to work on your diet more than anything else. If their diet is good, or if they're taking like a functional food, let's say, that provides protein and some fibers and phytochemicals, if they're having gas and bloating in that situation, then it's not a food problem, it's a digestive and microbial problem. So when a patient complains of gas and bloating, we have to look at this within the context of what's going on for them. The first question to ask is, well, what foods are triggering your gas and bloating? If it's, a triple-decker sandwich and a milkshake and a lot of sugar and French fries and all that, sure, we need to work on their diet. But if their diet's clean, or they're working to improve their diet and they're having gas and bloating, they're probably in some type of microbial mismatch, the relationship between their microbes and their food, and we have to help them kind of adapt their microbiome to whatever dietary change they're trying to implement. A lot of times people experience gas and bloating as they are improving their diets, and if they don't have some coaching through that, they may misinterpret it as a problem, or that they're on the wrong course, or that your diet advice wasn't good, or their supplements aren't good, or the medical food that you recommended for them isn't good. So we have to kind of coach them through this, and that's part of the main reason why I'm making this hopefully short video. So problem number 3 is ultra-processed foods, fructose, advanced glycation end products, lack of phytochemical and fiber diversity, in quantity and quality, we might say. Also, high fermentation foods, as I already mentioned, like wheat and potatoes, are certainly the worst among the high fermentation foods that people commonly consume. But again, as people adapt to a diet, or maladapt to a diet of ultra-processed foods, which represent about 60% of the diet in the United States, for example, as people consume that diet, they're changing their microbiome, and their microbiome is becoming less adaptable to a healthy diet. So as people eat junk food, their microbiome adapts to that junk food diet and becomes somewhat proficient at metabolizing a junk food diet. Of course, we don't want that, but that is what happens. The microbiome is always going to try to adapt to the diet because that's what the microbiome is eating. It exists off of whatever the human puts in there. So if you're putting in junk food, you'll eventually have a microbiome that adapts to junk food. And then if you try to switch to a healthier diet, that transition will be a little more difficult, and that's what I'm going to explain in this presentation. That's really the model of what I want to explain, is transitioning people from a poor diet, ultra-processed food diet, to what we might call a medical diet or a functional diet or a healthier diet. So problem number 4, underchewing or dental problems. That impairs the mechanical breakdown of food. So bigger food particles are being put into the gastrointestinal tract, and that's going to lead to impaired digestion because the enzymes and hydrochloric acid need to interact with the surface area of the food. And if the if the chewing aspect of eating isn't working well because a person's eating too rapidly, or they're distracted, or they've got dental problems, and they're not able to mechanically break down food, that's going to make all the other processes more difficult. Underdigesting, so people sometimes don't have enough stomach acid, whether that's due to an autoimmune problem or a prescription drug like so-called acid blocking drugs, proton pump inhibitors, and antihistamine acid blocking drugs. Pancreatic insufficiency, of course we see that with cystic fibrosis, but we also see it in milder forms with zinc deficiency. So zinc deficiency, you're going to see me mention that a few times in this very brief presentation. Zinc deficiency causes impaired smell and impaired taste. As a result of impaired smell and taste, especially in older patients, they just eat less. And as they eat less, because of their nutritional deficiencies, of course, their nutritional deficiencies get worse. So we see a vicious cycle there. Also, you might say, maybe in younger people, when they are zinc deficient and they lose taste and smell, they're going to pursue more stimulating foods, and that's usually junk food, back to ultra-processed food. And of course, those are nutrient deficient. So the maladaptation that people undergo with zinc deficiency that impairs their sense of taste and smell is they either eat less or they eat worse a lot of times. So that's a way that we might gain some insight through the history, asking the client or asking the patient, what's your diet like? How has your diet changed? Why has your diet changed? Those are all questions we can ask to gain some insight. Number 6, mucosal inflammation leads to inhibition of intestinal disaccharidases. So for example, let's say a person has a systemic inflammatory disease, like an autoimmune type disease. Of course it has a gastrointestinal component, as I've said now for 15 years or so. But what I want you to understand is that when people have systemic inflammation, they also have gastrointestinal inflammation because the whole body functions as a unit. And when they have intestinal inflammation, that leads to inhibition of the digestive enzymes that are kind of within the wall of the intestine. We call those disaccharidases, for example. And so when people have systemic disease, they often have impaired mucosal digestion. That leads, or I should say that leaves, excess carbohydrate within the gastrointestinal tract, and that can promote excess fermentation, then leading to excess gas production, which leads to bloating and pain. So that could be another way to gain some insight and not just say, oh, you've got gas and bloating, go talk to your pharmacist and, you know, give me something more interesting to work with. Let's not do that, even though I'm aware that some doctors do that, and every once in a while we might be tempted to consider this to be boring. I'm trying to show you some of the more interesting aspects of what might appear to be a boring topic. So let's look at gas and bloating as an opportunity to gain some insight. If you just think gas and bloating, that's one thing, but if you see a patient with gas and bloating and you say, wow, you've got mucosal inflammation, and so we need to deflame your guts, reduce your systemic inflammation so that your intestines can actually participate in the process of digestion and absorption, and then your gas and bloating will go away as a secondary benefit. Various causes of malabsorption, again, lead to excess substrate within the gut. That leads to excess metabolism or fermentation, again, leading to gas and bloating. Gastroparesis, we see that in patients with diabetes. Also stasis in patients with hypothyroidism or systemic diseases, again, like systemic sclerosis and scleroderma. Dehydration and fecal impaction. Anybody who's been a medical student certainly has a story to tell about fecal impaction. Dysbiosis, small intestine bacterial overgrowth, especially a small intestinal bacterial overgrowth that produces hydrogen sulfide, because that gas in particular can have a paralytic effect on gut motility. Antibiotics can promote dysbiosis and IBS by kind of inducing a severe imbalance if an imbalance wasn't present already. So let's assume a person has a somewhat normal gut and they get a skin infection or a sinus infection or a dental infection or whatever, and they're put on antibiotics. Those antibiotics can then induce some pretty radical changes in their gut microbiome balance and populations, and that could then lead to an undergrowth of certain bacteria that were killed off and a compensatory overgrowth of other bacteria that may present as gas and bloating. So you could ask about that in the history. Lack of movement and exercise, especially for people who either have office jobs, driving jobs, desk jobs, or quarantine jobs where they just can't get out of the house because we're all supposed to be trapped in our houses to so-called keep the population safe. I already have talked about that in other videos, so I won't get into that political topic. Even though if you want to learn about antiviral nutrition, you can certainly find out more on my website and in some other videos I've done. So lack of movement and exercise, sympathetic dominance, just too much stress, vagal suppression. So obviously we can reduce stress, we can increase vagal stimulation. And number 14 on this rather short list is any type of immunosuppression is going to promote dysbiosis and usually a form of small intestine bacterial overgrowth. So this could include HIV, again stress, immunosuppressant drugs like prednisone, again deficiency of zinc, and vitamin D. So zinc, vitamin A, glutamine, vitamin D, these are all nutrients that actually are necessary for maintaining gut immunity, and it's the gut immunity that controls the quantity and quality of gut microbes. So proof of this actually, we've been using this in clinical practice now, going on decades, but proof was actually published about the benefits of vitamin D in irritable bowel syndrome for example, reducing gas and bloating. And how does that work? Well, it works through the mechanism that I just explained. Vitamin D, as I already said, is necessary for proper immune responses and immune defenses, including the mucosal immunity within the gastrointestinal tract. So when people are vitamin D deficient, they need to be seen as being immune suppressed, and of course secondary infections would be the consequence. Those secondary infections could also include forms of dysbiosis, especially in the gastrointestinal tract. Conversely, when people are vitamin D replete, or they have enough vitamin D, then their immune system can function properly. That reduces inflammation. It improves their gut immunity along their mucosal surface within their gastrointestinal tract. That helps their body to control the quantity and quality of bacteria within their gut, and that can reduce gas and bloating. And to my delight, that's actually been proven in several clinical studies in some important journals. So these are certainly worth considering. So again, if you see a patient with gas and bloating, you could see that possibly as a way to gain some insight into what's going on with their hormones, their nutrient status, especially vitamin D and zinc, or other aspects of their life, and you could leverage that information into improving their overall health. So let me show you this in a diagram, actually the same diagram that I showed you before. So we'll review this very quickly. We're going to start kind of right here at the 3 o'clock position, we might say, with intolerance to fibers. So these are patients who present to your office with an inability to digest phytochemicals and fibers, and they say, you know, I'm following this healthy diet that you put me on. Maybe it's this great 5-part Paleo-Mediterranean diet that was published by me about 10 years ago, or actually 15 years ago for the first time. So maybe they're on that diet, or you're transitioning them to that diet, and they're not tolerating it. They can't tolerate the fruits, vegetables, nuts, seeds, berries. They get gas and bloating. So let's start here, again, at the 3 o'clock position with somebody who complains of being intolerant to fibers and phytochemicals. So again, that's a mismatch between their microbiome and their diet. Now, let's assume for a moment that a patient just comes in and we've maybe not seen them in a while, or maybe we've never seen them, and they say, my main complaint is gas and bloating. One of your first questions needs to be, well, what are you eating that triggers that gas and bloating? If they say, well, I went to Paris for Christmas break and had 4-cheese pizza and I ate the whole pizza by myself, then you say, well, don't do that. You know, that was a binge. You went on a bread buffet, and you suffered the consequences of that. That's probably not the answer to their question. More likely, or sometimes they will say, I'm trying to improve my diet, but I'm just not tolerating the transition. And a lot of times they won't even understand it enough to say that it's a transition. But you, as the professional, need to explain it to them. Well, of course you're not tolerating, more fibers and maybe even more protein and more phytochemicals. Your microbiome's not used to it. So, let's say for the past 15 years or so, 10 years, we're all familiar with the concept of metabolic flexibility, or we're increasingly aware of that concept. But the same applies to a person's, not simply their bodily physiology, but also their microbial physiology. And so when you're dealing with someone who's talking about, or when you're talking with someone who's dealing with, I might say, this gas and bloating problem, part of what you can help them understand is that they have a microbiome that's not representing or not demonstrating metabolic flexibility. So a healthy, diverse microbiome should be able to compensate within reasonable standards and limits to dietary change, right? If they're not able to make certain dietary transitions, especially in a healthier direction, then that's telling you that they have metabolic inflexibility, not necessarily of their own physiology, which could be true, but more specifically in this conversation, they're lacking metabolic flexibility of their microbiome. So they have an inability to digest and metabolize certain dietary fibers. That results in gas and bloating, especially if they're starting to consume more phytochemicals and more fiber. So naturally, unless you guide them, their own interpretation could be, oh, well, this healthy food stuff doesn't work for me. These supplements don't work for me. The medical food product that you put me on doesn't work. I don't know why I ever came here. Those would be some rather reflexive Pavlovian responses. So again, we, and in this case you, when you're working with clients who are having that response, you have to explain to them, especially if you could do this before it ever happens, look, you're going to go through a transition phase here. It usually lasts about 1 week, maybe 2 weeks. We can help you with other supplements like digestive enzymes. Maybe you need some hydrochloric acid. Maybe you need some magnesium. Maybe you just need to drink more water and get more exercise. But we're going to help you through this transition. Otherwise, what commonly happens is that patients become increasingly restricted in what they're willing to eat because they're afraid of triggering this gas and bloating. When they restrict their own diet, of course, that's a maladaptive response, because that's going to lead to a further restriction of the diversity of their intake of fibers and phytochemicals. That's going to basically starve off their microbes, and that's going to exacerbate the original problem that they didn't even know that they had, which is one of several forms of what we call insufficiency dysbiosis. Insufficiency dysbiosis. So this is a lack of phytochemical processing and fiber degrading microbes. one form of several. So, in my world of kind of studying and writing about dysbiosis, I don't just talk about dysbiosis, I talk about different types of dysbiosis and different subsets of those types of dysbiosis. So, one form of dysbiosis is what we call generally insufficiency dysbiosis, and that was actually a phrase coined by Leo Gallen back in around 1994, so a long time ago, 25 years ago to be exact, when I first started studying this. So that's insufficiency dysbiosis, a lack of the good bacteria. Well, what more specifically could that be? I mean, we have different types of good bacteria. In this case, I'm talking specifically about those good bacteria that digest phytochemicals and fibers. So typically what we see in that situation is also a lack of production of butyrate and perhaps, most likely, an excess of acetate, which promotes certain aspects of diabetes and obesity and weight gain, also an excess of propionate, which promotes certain types of neuroinflammation, cognitive dysfunction, and mitochondrial impairment. So this is exactly the cycle that we're trying to break when we're telling patients that they need to consume more fibers and phytochemicals. If they don't understand the adaptation phase, they could try to jump ship, and that would only limit their intake of fruits, vegetables, nuts, seeds, berries as phytochemicals, as sources of phytochemicals and fibers, and that's just going to perpetuate the problem. So we have to tell them, you're going to go through a transition. I'll help you through the transition. We'll use some enzymes. We'll support your pancreatic digestion. We'll support your stomach digestion with hydrochloric acid. We'll make sure you're not hypothyroid to make sure that everything's working as it should, but you are going to go through a transition phase. It could be very easy, or it could be less than easy, and it might last 10 to 14 days. So, again, as a consequence of this insufficiency dysbiosis, these patients commonly also have an inflammatory dysbiosis along with their insufficiency dysbiosis, and we haven't even talked quantitatively in terms of small intestine bacterial overgrowth, even though I did mention that previously. But a lot of times when they have insufficiency of the good bacteria, they have an excess of the bad bacteria. Some of those bad bacteria promote inflammation at the intestinal level as well as the systemic level. So to get patients out of this vicious cycle, we have to kind of reverse, kind of like reverse engineer some of these problems, but we have to at least start with an understanding of these problems. So, number one, understand the mismatch, tolerate it, manage it, anticipate it, explain it. As the new, healthier microbiome is being cultivated, and as we're grooming that new microbiome with diet, supplements, maybe hormones, especially thyroid hormone again, as I mentioned before, certain botanicals we can use, we need to optimize digestion, peristalsis, and elimination. So we're doing a lot of things while we're transitioning patients to a healthier diet. Number two, strict consumption of a healthy microbiome supporting diet. Again, fruits, vegetables, nuts, seeds, berries, medical foods, functional foods, fibers, phytochemicals, in order to cultivate the new and improved microbiome that we want. Again, cultivate that phytochemical adapted microbiome with functional foods, select probiotics, and eubiotic substances such as berberine, which kills off some of the acetate and propionate producing bacteria and promotes the butyrate producing bacteria. So that's a really good strategy that you can implement. Sometimes 500 milligrams is sufficient. Sometimes we use 500 milligrams 2 or 3 times per day, up to 1500 milligrams per day for a period of up to 3 months, especially in the more complicated patients. So if a patient simply has a little bit of gas and bloating, you could use 500 milligrams of berberine per day. That might help. If they've got more gas and bloating and they're overweight, then 500 milligrams twice a day. Gas and bloating plus overweight plus insulin resistance and diabetes, okay, 500 milligrams 3 times a day, still very, very reasonable. Number 4 on my list here, heal the gut. So again, some of the nutrients that we can use there include whey protein, assuming the patient's not allergic, glutamine, zinc, vitamin A, vitamin D, and a whole list of botanicals. Normalize immune function. We could use the nutritional immunomodulation protocol that I've published in my Inflammation Mastery textbook. We could use select antimicrobials, again, such as berberine. Also, some antifungal botanical combinations. Also, oregano oil is uniquely popular and beneficial as well. And finally, number 5 here, improve systemic health to break what I call here the inflammophilic cycle. So again, when people have systemic inflammation, that inflames their guts, that changes the milieu or environment within their guts to promote the growth of inflammatory bacteria. That's why they're called, well, so they produce, let me say this again. So let me explain that. When the body has systemic inflammation and therefore gut inflammation, that promotes the growth of bacteria in the gut that enjoy inflammation. They adapt rapidly to that environment, but they also create more inflammation. So they receive and benefit from inflammatory signals, and they also produce more intestinal damage to promote the inflammation that benefits them. That's why we call those bacteria inflammophilic bacteria. So thank you very much for your attention during this rather brief presentation, but I want all of us to understand this gas and bloating topic. We discussed it recently in one of the functional medicine and nutrition forums, but I wanted to provide this review because I felt like some of what I was hearing represented a lack of appreciation of this topic. And sure, gas and bloating, most people aren't going to try to specialize in that in their clinics. But rather than seeing it as irrelevant or, hey, I only deal with big league problems, see gas and bloating as a way to gain some insight. It may not be, the thing you want to specialize in, but it may be something that you can use as a tool to understand and help your patients as you focus in on whatever it is your favorite topic is in your clinical practice. So again, this has been Dr. Alex Vasquez coming to you live to talk about gas and bloating. Let's look at it as a bothersome bonanza. Yes, it affects 30% of the population, and it can also provide some big insights for you, your patients, and of course, your clinical practice. So again, Dr. Alex Vasquez here. You can learn more at inflammationmastery.com/IBS.